They've been here for 18 minutes.
The long dome,
So can they see this or what?
Yeah,
They'll be able to.
they're right here, and we're right here.
Tommy tubes and IVs.
Yeah, there's a IV. Is that on a? Is the IV on a dummy?
Well, that's what I was gonna ask Becky, but I think it's on the arm, on the dummy arm.
We better practice that.
Did everybody get all these I sent out?
Where's Brennan?
and you have to totally hook it up.
And then I didn't send out the ones that they gave us last week or last month on trauma and medical. These are just the other ones.
I don't have
Becky,
patient assessment for trauma.
yeah, you should have had that from last week.
How different is that from the B? It's just that in your airway and your medications allowed would be different, right?
Would be different, absolutely. It's gonna be the same thing that you did for the B, London. The only difference will be on, I think Becky told me there's 7 of these that you have to do. The airway is one that you have to do. IV therapy is one that you have to do. It's new. The pediatric interosseous infusion you have to do. I don't even think we got a pediatric needle anymore. I can't find it.
Yeah, I'd like to practice IOs.
Yeah.
Yeah. And then I don't know on the others if, I think bleeding control, shock management is one that you have to do.
Will we know for sure before the test?
Yeah, I'll check with Becky again. Cardiac arrest management, AED, I believe you have to do. Now, there's some optional ones, I guess they picked the day of.
Yeah.
And I think it's the others that I have here. It's spinal immobilization supine, spinal immobilization seated, pediatric, respiratory compromise is a have to. I'm pretty sure on that one.
Unless not.
And then the long bone immobilization is going to be a long or an arm bone, I think is one of the 4 that they choose from. I'll find out for sure from Becky on that, how they do that the day of. I have not gotten anything back from Scott yet on the actual date. He told me it was going to be in May, but I don't know exactly when in May.
Why are they doing long bone mobilization? Isn't that a basic skill?
It is, but they picked some of those, Mark, apparently to throw in.
We're still required to do them if they need it, I guess.
What we do, I
We
mean,
don't just.
on a basic.
I don't know, I'm just a heavy pitch on.
London, I don't know why, it must just, I know these are big files and they take a long time to come down.
Well, and I think some of it is that some states actually do this as
How
a
are we doing
basic.
focus slides?
It's the same, I went through it last night, there's really no difference in the 2.
I looked at the wrong chapter yesterday. I didn't look
You
at much.
didn't?
Oh my
I
goodness.
attempted and stressed out.
Hey, Shane?
That's good.
London, you want to see if we can do it, if I can speed
Where's your
this up
son?
or if I just give up? I'm so close, I'm right
yeah,
there.
I mean, I would say just wait a little while and see if it'll go. There's an audio book. What am I doing with my life?
Yeah, I've been listening.
All right, well, I'm gonna go.
It says open link in a new tab, so I'm gonna open it where?
No, that's what you want. No, that thing you have is what you want.
Oh, that-
For the 84-year-old guy?
70 something.
Okay, this tab right here.
That's him.
my neighbor,
The save?
I have a neighbor. It wasn't him.
It's just super
He's
simple.
all right. Right.
How do you know?
Oh, there you
he's
go.
not her new neighbor.
Shh, I apparently was hitting something wrong. Thank you, London.
Yeah,
Ah.
Oh.
and it's not quite open yet, but.
It takes a while, you know,
know
on my
how,
computer, so I hate to think how long it's gonna
Carolyn
take on this one.
Have you heard
It's a powerful.
Why be hollered?
of it?
There
Not
you go.
lady, she-
Oh my
I think
goodness.
we life flighted her after we helped her last time.
Oh, all right.
Yeah.
So I go slideshow,
Oh, I gotta do that.
And heart
How do I
failure.
get it to-
Heart failure.
jump into
Heart failure for years.
I know. She just looked like shit.
from beginning.
Huh?
Yeah.
Okay,
Look at the big heart attack she had years ago.
and then you got a clicker thing you say?
That might
Yeah.
have been before I knew her.
She had massive
Is it a?
Cause I didn't get to know her until
Yeah,
Al
like-
started having all his issues.
Oh, this has got a-
And I screwed up
Oh.
that night cause he fell and he was home by
What?
himself, so I gave him my phone number. So
Or you can,
then he called
or you
me.
get a remote.
You're hitting on patients again?
Yeah, it was when I gave my phone number to Al Solomon.
Oh, I
And
remember that,
he
then you
and
went to the
Carolyn
house.
called me all the time after that, which was fine, but now they have Sue and Andy across the street, so that makes me feel better.
That's good.
Does Sue and Andy live there now?
Sue and Andy live right across from Carolyn, so that makes me feel better. They're really good about checking in on her.
Well, hey, I'm gonna run through shock
Yep.
quickly, then I'm gonna turn it over to Mark.
He's gonna run through respiratory.
Um, Shock, state of collapse and failure of the cardiovascular system, failure to perfuse. Body attempts to maintain homeostasis in the earliest stages. Shock, blood circulation slows and eventually ceases. Shock can occur because of medical or traumatic events. Be constantly alert to signs and symptoms of shock. Perfusion, circulation of blood within an organ or tissue in adequate amounts. Cardiac output, volume of heart can pump per minute. Myocardial contractibility, and preload and afterload. Preload is what?
When the
As
heart
it-
relaxes,
heart feels-
As it fills, it's
So
getting ready
relaxing.
to
You said it's
pump.
relaxing? So the heart relaxes. Yeah.
If you want to figure cardiac output, it's heart rate times stroke volume. I don't know how helpful that is to us, but it's certainly there. Blood pressure is cardiac output and systemic vascular resistance. We get diastolic blood pressure and systolic blood pressure is the map. It's the difference between the two.
that's a 1/3 of, so you take the diastolic and you take 1/3 of the difference between them and add it to it.
And add it to
And
it.
that's what is that number?
Map,
That's the
Diastolic blood pressure plus
medium,
1/3 pulse
median,
pressure.
Cause on my app, that question
median
comes up.
arterial
Oh,
pressure.
yeah, that question comes up a lot on practice things, and
It
it's
does.
so diastolic plus 1/3 of the difference between them. And on the app, the answer is 75.
So if it's 120/80,
Well, I finally kinda figured
So-
out that
blood
it's
pressure's
kinda,
120/80.
Yeah, it's 1/3 of 40 plus 80. So it would be 110. Is that 1/2 of 1/3? Yeah, 1/3 of 40.
we could
Maybe
use
these would be-
calculators.
So it would say 140/80 would be 60, which would be 1/3 would be 20.
Yeah, so then you would add 20 to 80 and your map would be 100.
Okay, that's what I was thinking. but-
And what does MAP tell us?
It's the median,
Arterial pressure.
I think is correct, yeah.
Median arterial,
pressure.
mean arterial pressure,
Mean arterial pressure.
1/3 pulse pressure.
Okay, they talk a lot about the autonomic nervous system, controls the cardiovascular system, it regulates the upper part of the medulla. It's regulated by the medulla oblongata of the brain. Sympathetic nervous system prepares the body for physical activity during a stressful situation, fight or flight. And then the parasympathetic nervous system is responsible for rest and regeneration. It tries to hold down the autonomic system. Perfusion, pupils are dilated. When you initially get in, heart has an increased rate, increased force, contraction, trying to, arteries are constricted. Lungs, bronchial muscle relaxation, GI tract slows down.
So this is sympathetic versus parasympathetic?
Correct.
Right.
They don't have it labeled very well on that.
No, I don't care for this one, to be honest with you, but.
So the right side, the right
Left.
side of that is your parasympathetic.
Right here. This is what's
Yeah.
trying to shut you down. This is what's trying to run you up.
What? 19%.
In the blood vessels, there are sphincters.
I knew you would do that. I was like, oh, here comes Tyler.
Tyler, what do you think of that? Regulate the blood flow through the capillary beds, determined by cellular need, accomplished by vessel constriction or dilation. Maintenance of perfusion is accomplished by the heart, blood vessels, and blood all working together. The other part of this is you have to oxygenate the blood. Oxygenated blood passes through the alveolar wall into the pulmonary capillaries, diffusion of oxygen from alveoli into the blood. It also breaks down carbonic acid, and carbon dioxide is exhaled. Shock results from inadequate cardiac output, decreased SVR. Somebody help me. Stroke volume?
SVRs.
Systematic vascular resistance.
Oh, okay.
What was it?
Vascular resistance.
Yeah.
Systematic vascular resistance. Is that what you said?
That would be
Do
the
you have a
blood
list
vessels
of
opening up.
acronyms? 'Cause there's a couple I tried to find last.
Inability of red blood cells to deliver oxygen to tissues. Body attempts to compensate by shunting blood flow from more tolerant organs to vital organs. What would be an example of a more tolerant organ that it wouldn't be necessary? Stomach.
Skin,
What would be a vital organ?
Heart,
brain,
Heart,
Brain, definitely. Brain, heart.
not for trash.
Lungs?
lungs.
I like having you around.
Do I need to review pathophysiology? I think we've all looked at this numerous times. Anything anybody needs to know about this?
Everything.
Everything. I can go back, London. I hope I can walk my way through it.
No.
Heart pump function. Damage to the heart by disease or injury decreases the ability of the heart to pump properly and function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. Blood vessels. If all the blood vessels dilate rapidly, normal amount of blood volume is not enough to fill the system, provide adequate perfusion for the body. If all of your blood vessels would suddenly dilate,
Volume's gonna be in your.
yeah, you wouldn't have enough volume in your body to get through. It'd be similar to hypovolemic shock. You just don't have enough blood in the container.
Yeah, what are the two categories, three categories of shock?
We're gonna get to those. They're coming up, I promise.
Okay.
Blood content function, is there enough blood or plasma loss for someone who has a massive bleed? Blood is the vehicle for carrying oxygen. Nutrients, contains red blood cells, white blood cells, platelets, and plasma. Blood clots control blood loss, formed depending upon retention of blood, changes in the vessel wall, blood's ability to clot. Body's neural and hormonal mechanisms are triggered when body senses failing pressure. Sympathetic nervous system assumes more control of the body's function during a state of shock. The parasympathetic nervous system controls involuntary functions. Compensation for decreased perfusion. Baroreceptors sense decreased blood pressure and flow. Chemoreceptors measure shifts in the amounts of carbon dioxide in the blood. Stimulation occurs when systolic pressure is between 60 and 80 milligrams.
What was that again, between 60 and 80?
60 and 80 is when they kick in. Hypoperfusion. The renin angiotensin adultostone system activates release of antidiuretic hormone. Initial compensatory mechanisms increase preload, stroke volume, and pulse rate. So what's going to happen when you first start into shock?
You're gonna
Heart's gonna-
compensate.
You're going to see what?
Heart rate increase,
Heart rate increase.
heart volume increase.
You're probably going to
Heart's gonna work
see pressure's going to go up.
Yeah.
Mm-hmm.
Autotransfusion effect allows the body to compensate for a volume loss of up to 25%. And I'm pretty sure that'll be on a test somewhere.
Autotransfusion effect, that's pulling blood from other areas? Is that what-
Pulling blood from other areas, also possibly constricting of arteries or veins, in some respects. Your body can compensate, and then you'll finally dump.
So then that's why somebody would look pale.
Mm-hmm.
Yeah, they might look pale, but you know, when they first go into shock, you don't know that they're in shock typically. They could be talking to you, their brain is still perfusing, They still have a pretty good level of consciousness, and then when they finally dump, that's when all that stuff goes. Who's really notorious for dumping hard?
Kids.
Kids and elderly. As hypoperfusion persists, myocardial function worsens, tissue perfusion decreases, leak of fluid from the blood vessels, perfusion to the brain and coronary arteries decreases. How are you going to tell when that happens?
Confusion.
Confusion, yeah. Cells switch to anaerobic metabolism, and then you get that shot of epinephrine or norepinephrine. Your body's going to attempt to compensate. Pecking order, plan shunning the blood from areas of lesser need to areas of greater need. What's going to be the greatest area of need?
Heart, lungs, brain.
Heart and brain. Failure of compensatory mechanisms to preserve perfusion results in decreases in preload and cardiac output. Shock-related events at capillary and microcirculatory levels. Cellular ischemia occurs with decreased perfusion. Anaerobic metabolism starting to build up. Lactic acid. Acidosis serves as an indirect measure of tissue perfusion. Dysfunction of the sodium-potassium pump. Capillary and microcirculatory levels, cellular flooding releases lysozymes. They talked about all this.
Lysosomal.
Yeah, lysosomal enzymes. Continuing buildup of lactic acid and carbon dioxide acts as a potentially vasodilator. So what's that going to do?
Open up your stuff.
Open your veins up even more, yeah. White blood cells and blood clotting system are impaired. You got intravascular coagulation. Disseminated, can occur. Multiple organ dysfunction syndrome, combined failure of several organs, occurs when injury or infection results in release of numerous inflammatory mediators. Septic shock would be an example, I guess, of an infection. Activation of a complementary system, coagulation system, and go ahead, Amy.
Kallikrein-Kinin.
Kallikrein-Kinin system.
Kallikrein-Kinin.
Kallikrein.
Okay. Multiple organ dysfunction, signs, symptoms. What are you going to see? Well, low blood pressure, insufficient tissue perfusion, uncontrollable bleeding, multi-system organ failure caused by hypoxia, tissue acidosis, and severe local alterations of metabolism. Respiratory inefficiency, insufficient concentration of oxygen in the blood. Let's say you've suffered a traumatic chest injury. Could that cause insufficient concentration of oxygen in the blood? You can't inhale. Poisoning may affect the ability of cells to metabolize, because what's going to build up in the cells? Carbon dioxide.
Or carbon monoxide. Could be the
Or
same thing.
monoxide, right?
Yeah, anemia, abnormally low number of red blood cells could also occur. Causes of shock. Bleeding, where?
Internal or external?
Yeah, internal or external. External is easiest to see, maybe easiest to treat. Internal is always one that you got to think about. What leads you to think about internal bleeding?
Distension of the abdomen.
Distension of the abdomen. How about mechanism of
Injury.
injury? Is that what Shay just said?
Mm-hmm.
Also your blood pressure, pulse.
Respiratory failure.
Diet.
That could certainly do it. What could cause respiratory failure?
Not breathing.
Not breathing.
Not breathing. Very good. What causes not breathing?
Occlusion, so like choking.
Absolutely, someone choking you.
Collapse lung.
Or
Drowning.
Tension pneumo maybe, huh?
Drowning.
Being dead.
You could have a tension pneumo. You got two problems probably. You got bleeding internally, and it's pushing the lung shut so you can't inflate. Acute allergic reactions, anaphylaxis. And lastly, infection, I mentioned.
Just septic.
Yeah. Expect shock if a patient has multiple severe fractures, abdominal or chest injury that hit the steering wheel at 70 or 80. Spinal injury. What happens in spinal injuries?
It's a neural shock.
Neuroshock. Yeah. Severe infection. Mark mentioned septic infection.
Septicemia, all that stuff.
Major heart attack or anaphylaxis again. Hypovolemic shock due to inadequate blood volumes. Hemorrhagic and non-hemorrhagic causes of hypovolemic. Non-hemorrhagic, when fluid loss is contained within the body. Abnormal losses of fluids and electrolytes, dehydration may occur through vomiting, diarrhea, increase in excessive sweating, internal losses, peritonitis, pancreatitis, ileitis, plasma losses from burns, drains, and granulating wounds. Other causes include ascites, diabetes insipidus, osmotic diuresis secondary to hypermolar states. I'm not familiar with that one. Expect signs of shocks. Earliest signs of shocks are restlessness and anxiety. Patient may be thirsty, pale, calm, clammy skin, heart speeds up. As bleeding or fluid loss continues, blood pressure falls.
Hyperosmolar state is a complication of diabetes.
Complication of diabetes. When are you likely to see blood pressure fall?
Right, like, as.
Hypovolemic shock.
Well, right towards the end. By that time, you're already behind the ball. If blood pressure dumps, are you going to be able to get an IV when they go down to like 60/20?
Interosseous, bam.
Interosseous, that's right, Amy. But you're probably not going to find a good vein
No.
at 60/20.
Jugular cut down.
What?
Jugular cut down.
Well, you're familiar with that process.
No.
Your
I've seen it
patients
done.
never complain though.
I've seen it done once.
No.
No?
You were over on the floor by then.
Cardiogenic shock caused by inadequate function of the heart pump develops when the heart cannot maintain sufficient output. As afterload increases, cardiac output decreases. Obstructive shock results when conditions that cause mechanical obstruction of the cardiac muscle also affect pump function. Cardiac tamponade. What do you look for in cardiac tamponade?
Decreased pulse.
Muffled heart sounds.
Muffled heart sounds, and then
At the end.
narrowing pulse pressure. When you sit there and you've got a systolic of 100 and you got a diastolic of 90. When that gap gets closer and closer, you probably got a cardiac tamponade. Obviously, tension pneumo, decreased breath sounds, pulmonary embolism. Distributive shock results when there is widespread dilation of the small arterioles or small venules. Septic shock is a result of severe infections. Take a look at the blood vessels, how much they can change, dilated versus normal. Neurogenic shock due to a damage to the nervous system that controls the size and muscular tone of blood vessels. What could cause that?
Spinal injury.
Spinal injury, head, neck trauma. All vessels below the level of the spinal injury dilate widely, increasing side capacity of vascular system. So if someone's broken their neck, clear up here, that's a huge amount of area for those to dilate. Probably gonna have a tough time filling that vessel. Let's say they break their lower back.
Also not good.
Not good, no.
Better.
Better than probably your neck. Anaphylactic shock occurs when a person reacts violently to a substance of which he or she has been sensitized to. Do you typically have an allergic reaction the first time you're
No.
exposed to something. No, it's typically after you've been exposed a few times. You can have a bee sting the first time, maybe you get a little redness or whatever, no big deal. Then the next time you have that bee sting, suddenly you got a real problem. Results in widespread vascular dilation, increased permeability, so the walls of the vessels actually begin to leak, and you have bronchoconstriction. Can't move any air either. Psychogenic shock, a sudden reaction in the nervous system that produces temporary and generalized vascular dilation and results in fainting. Shock occurs in two successive stages. First one is compensated shock. Early stage of shock. Chemical mediators are released by the autonomic nervous system, pulse, pressure, systolic pressure, diastolic pressure, all stay pretty good at the first part. They pick up a little bit, but you're not in trouble yet. Decompensated shock, late stage. Blood volume decreases by more than 30%. I guarantee you that'll be on a test somewhere.
Go back then, what? I checked out.
Decompensated.
You're not taking the test anyway.
I know, I
fine.
keep going back and forth.
30%. Compensatory mechanisms begin to fail. That's those late signs where we look at blood pressure and we go, oh crap. Then you hit irreversible shock. What's that mean?
Maybe there's a shock that's
Failure.
reversible.
Say a final prayer.
Yeah, you're probably not going to make it. Shock that's progressed to a terminal stage. Arterial blood pressure is abnormally low.
Well, not with that attitude, she's not gonna make it.
Life-threatening reductions in cardiac output, blood pressure, and tissue perfusion. Scene size up. What do you do when you come to that system, that patient? You're going to look for and address hazards and threats to the safety of the crew, the bystanders, and the patient. Primary survey. Perform a full body scan of the patient as you walk up. You're looking at him. Identify and manage life-threatening concerns. What would be some example of life-threatening concerns you might see? Airway, breathing, circulation. Right off the bat. Assess the patient's breathing, assess the patient's circulatory system. Are you going to want to go beyond these until you get these controlled?
No.
No. You might say, oh, that really looks bad. You're bleeding a lot. Let's move on now to secondary assessment. I'll come
Are you
back.
on any medications?
Do you have any allergies?
Yeah, should we stop maybe and fix that?
You're bleeding outside of my body.
Okay,
Usually don't
hear me
respond
out
like
though.
that.
The internal bleeding is better because it's still in your body, which is where it's supposed to be.
Okay, now, one of the things that I like about this, they say, look, you get to this thing and you see that the circulatory system status is not good. You put a tourniquet on or you put direct pressure on. They talk about gain IV access early. So go ahead and start that IV. Treat aggressively and provide rapid transport. That's kind of a load and go deal. If you're already at this point, you want to get going. History taking. Certainly a good deal if they can answer some of these. That shows some perfusion. Determine chief complaint. Obtain a medical history. Quickly obtain a sample history. If they're on blood thinners, what are we going to tell the hospital?
Trauma partial.
Yeah, we're going to let them know they're on blood thinners, trauma partial.
They really don't like that. Like I called on our last one, I'm like, let's call it partial trauma, and she's like, well, I guess we could. I'm like, it's like,
It's the second thing on our list.
it's like,
If you say talk to Joanne, she just told us we needed to call more.
I was like, well, we need to. And like, he's on blood thinners, he fell. Head injury. I was like, partial trauma. Well, I guess we could. No, we're calling a partial trauma, is what I said.
Perfect. That's exactly what you needed to say.
It says right here on my pink sheet.
What happened when you got in? Did they?
No, they were there. I mean,
But did he say anything else?
no, I mean, he had a facial injury and had,
Yeah.
I mean, he was on blood thinners, he was, all of those things, so.
Bless you.
But,
Thank you.
and everybody was there when we got there that should have been called for a partial trauma, but it was just like, we're gonna call a partial trauma. I'm like, well, I guess we could, and I'm like, no, like, we're calling a partial
You're right,
trauma.
we could and are.
Well, like the guy we had that night said, well, I'm not taking it.
You gotta get on the scene, I wanna see what.
Yeah, I don't wanna hear about it now. Call me back later.
I miss him so much.
Is that Travis?
Yeah. Amy was so mad when she got off the phone.
He was not my friend.
Call back
That
1
was-
second
that
later.
was-
Well, we're here now, partial trauma. You're there already?
You
Yep,
realize
better
when
believe
Travis-
it.
You realize when Travis got switched to day shift, he was great with us.
Well, sure.
He just didn't
Of
like
course.
But
me.
you know what?
He
He
didn't
said,
like me.
he says, Amy trained me well. That's what he told me. I understand why you guys do this now. Amy trained me well.
Uh-huh.
Well, it had nothing to do with Amy, it's what we were told by you in the hospital.
What'd I say?
He didn't like me though.
Actually, he did. He honestly did.
It was just
He was a
like-
dick.
I think that might be a stretch, but we'll go with
No, he
it.
really did like. I said,
Hey, secondary assessment, what do you start with? You repeat the primary. Once again, if you find problems with airway, breathing, C-spine, you're gonna wanna deal with it again, and it could happen. Do a full body exam, obtain a complete set of baseline vitals. This is where you finally get to a complete set of baseline vitals in that secondary assessment. Use monitoring devices to quantify the patient's oxygen and circulatory status. What would be some monitoring devices we could use?
Speedometer, or whatever that is.
Glucometer, yeah?
Big mama.
No,
Circulatory status, I don't think so, but
Pulse ox, is that what-
pulse ox is what they're looking for. Then the other one would be, if we had it,
No, when we get it.
when we get it, the CO2
Or just like,
capnography.
Yeah, cause
Yeah,
we heard that was a
capnography,
really
that
good
was
thing to
good.
get.
That capnography thing. My
We gotta
birthday's
get a
coming
plastic
up.
scoop stretcher first.
That's what I want for my birthday.
According to the hospital, I don't know.
that's what I want for my birthday.
Just so you know, that's what I want for my
I got
birthday.
new EMT pants.
Hey, reassessment, how often do you reassess?
No.
Every 5 minutes.
On their status, minimum
Depending-
within 15 minutes. If they're worse, obviously gonna do it faster.
Minimum 15, if it's worse, maybe every 5 as you're
It's on
coming
a
in.
You press the
transfer.
button.
When you
as
have a
fast
transfer
as you
that's
can.
3 minutes long, it's gonna need.
And you run out of oxygen.
Yeah, and you're on your way to Casper and you're running out of oxygen.
If we have two, by the time you get in there, you did really good.
Drive a little faster, so we have.
You've met the
You've met the criteria. To go.
Treatment begins during the assessment process. Control all obvious external bleeding first. Place patient in position dictated by local protocol. They talked about Trendelenburg and not being effective, that a lot of places don't use it
Oh, really?
anymore. Yeah.
But your cots do go into Trendelenburg position.
No.
Yep.
Do they?
They sure do.
In the back of the ambulance?
They do?
How?
Didn't know
Lift up
that.
your foot. All you do is lift up the foot in. It'll actually raise up.
Well, there's certainly a lot of, according to the book, different information that says it's not effective.
What is our local?
Our local protocol would be to do that,
Okay.
if I remember correctly, at least that's what we
It's
used to
it's
have.
one of those where if nothing else is working,
Well, is it gonna cause damage to do it?
no.
No.
Then I would say.
The only
yes.
one that could potentially cause damage are the mask trousers. And I don't even think they talk about it now, do they?
Well, mask is not recommended at all for shock. It is recommended though for
Pelvic fracture.
pelvic fractures. It's probably the gold standard on pelvic fractures in a lot of respects. They did talk about, what would be a complication of Trendelenburg if you suspect a
Neck or back injury.
neck or head injury. Head injury especially, you wouldn't want to increase in
Small one.
intracranial bleeding if
Yeah.
that might be what's bringing on your issue.
Okay.
Provide warmth. Gain IV access, administer fluids. The golden hour is the first 60 minutes after the injury if we're there by then. Provide initial management for shock, manage the airway. If you don't have airway, you don't have anything. Administer supplemental oxygen, place the patient in position of comfort, obtain vital signs, obtain IV IO access for medication or fluid bolus, maintain body heat, crank the heat. IV therapy, IV lines are inserted to provide a route for immediate replacement of fluid route for potential replacement in patients at risk of losing substantial volumes of blood,
Tuesday.
route for administration of medication.
Yeah, it was in my fire pants.
Special considerations: administer only enough fluid to maintain radial pulses. What is that going to come down to as a systolic pulse? If you got a radial pulse, you got a pulse of 80, if you can feel it, minimum, if you got a radial pulse.
80, that's right.
Radial here is 80. They're telling you when you start putting in fluids, if you still got that radial pulse, you're going to give them in, I think bolus is 250 or 500 milliliters initially. If you can get that radial pulse with 250, with 250 milliliters, you're probably going to go back to TKO. What they're saying is you don't want to just dump in a liter of fluid.
Yeah, they'll have fluid, but they won't have any oxygen carrying.
Exactly, and also if they're bleeding out internally, you're just going to help push that on out if you run that pressure up. So you want to maintain radial pulses, which is about a systolic of about 80. I don't know about a Broslow tape.
That's that color-coded thing that they will pull
For
out,
kids.
and that tells you what size everything is and what their value should be.
So that's obviously referring to children, that,
Yeah.
that question.
Something tells me we don't have one of those.
The hospital does.
Hospital has one.
No,
Yeah.
we have them.
Oh, do we?
Where are they?
Yeah,
They're in the cabinet under,
baby.
yeah, under, right there by,
Morning.
the back of the cabinet.
Never used it.
We never had, yeah.
I see him, so we propped that kid who had been hit on, ran over, they thought had been run over on Black Mountain Road.
Uh-huh.
And that was the first thing they did when we got there, is they pulled that out and they said, you know, whatever color it is, then their bag has the proper size and everything and instructions for whatever size.
At the hospital.
At the hospital, yeah.
Okay, I was gonna say, 'cause you guys did that in the back of the ambulance, I'm impressed.
But if we could get that information to them ahead of time, they could have it ready when they
Yeah.
got there, huh?
Mm-hmm.
Yeah,
Yep.
so if we have the chart, I mean, that would, and can locate the chart, that would be great.
Yeah, Jim, we put that in there, remember? Before.
Oh, I've slept since
I
then,
know.
Mark, I'm sure when we went through
Yeah,
that,
if
we
we
did
can find
that.
That's one of
that
the
would
things
be
we
good to
ordered,
remember.
and it's those
'Cause they would-
Broslow tapes are in they should be in the back upper left cabinet. With the.
Back by the door, the bay,
Yeah,
doors,
back with, you know, the
pregnancy.
pregnancy stuff and all that, right.
Okay.
Maybe we'll look
Maintaining
at the next time
fetal
we're in there.
perfusion, the only way to do that is to
Don't throw
maintain the
them away.
mother,
Yeah.
treat the mother aggressively.
Those do not get thrown away.
Broslau. Broslau?
Treating hypovolemic shock, control all obvious external bleeding first. Establish at least one 18 gauge or larger, so 18 or 16. Secure and maintain an airway and provide respiratory support, monitor patient's mental status, pulse rate, blood pressure, provide rapid transportation.
So you see that where it says at least one? So in other words, if you got a lot of bleeding, if you got, and you're able to, go ahead and start IV in the other arm as well.
We had one on either side for our guy out on Black Mountain.
Yeah, I just want to be careful, you know, we gotta check, that guy, I don't think we could have put enough fluid in him to do, I mean, I didn't have a radial pulse when I found him.
But one of the reasons they want you to go 18 or larger is they can give blood with that. With an 18, they can't with a 20.
Oh.
16
So that's
too.
why they want you to do an 18 or larger. Well, if you can get a 14 in there, go for it.
We don't have a 14,
Yes, we do.
All right, well, I feel good when I do 16.
not anymore.
No, 14s we use for darky.
Yeah, we don't have one.
Only 'cause he made me.
It's gone.
Yeah, it's gone.
Okay, I'll donate her.
Ensure systolic blood pressure greater than 90 before administering nitroglycerin for cardiogenic shock. Talking about cardiogenic now. Position and patient in position of comfort, administer high flow oxygen, gain prompt transport, gain IV access, administer fluids at TKO rate. Don't want to flood it at them. Obstructive shock, cardiac tamponade, increasing cardiac output should be the priority. Apply high flow oxygen. Tension pneumo, high flow oxygen via non-rebreather.
So let's-
Decompression of the injured side of the chest, with needle decompression. However, A's aren't allowed to do that. I's
That's the
could,
weirdest thing.
but now that we're an asterisk I want Mark to find out if we're still good to do what we were certified to do before. We need to figure that one out.
They're saying an A can't do decompression?
No,
They
they can't.
can't, we talked about
Paramedic.
that at the last class.
Just paramedic.
But I thought the one guy from Casper contacted our head state dude and said that we can do them still.
No, I think we can, I think, but we need to find that out. Because I made the comment, we need to make a contact on that and just see.
I just thought he did that day, he made contact. with
Because
us.
then I don't know if I want to become an I or an A then if I can't do,
Exactly.
though it's not something I've used a lot.
Well,
How's that?
are you both, or does your A replace your I asterisk?
Maybe we'd be an A asterisk.
Maybe.
Well,
You get,
it
you get
won't
one
be-
more asterisk.
It won't be in your, in that stuff when you go to fill in all your stuff for renewal.
Yeah.
It won't be there, so it won't show that you've been practicing it.
It's not showing that now.
Yeah, well, nothing's showing up now. They just take our word that we've done it.
Now, I would like to know for sure.
Yeah, that's something I
I can't
can,
believe that's
If we
not an A.
become A's, if that takes that away, then
It
I'm
looks
not
like
saying
it's only paramedic now.
Thanks.
That's just stupid. It's a simple little procedure.
I
Well,
would like to get some more practice.
at NREMT level, that's a problem apparently, so.
Well, yeah, cause it, what? Well, that was asinine.
Pulmonary embolus, assess blood pressure, provide fluid bolus. What's a crystalloid solution? What would be an example of a crystalloid solution that we would carry in the ambulance?
Not ILR.
No.
LR is a
LR.
crystalloid, so is normal saline.
Okay.
What would be a
Colloid,
colloid?
that would
The
be,
other one. the
D5.
one-
Yeah.
Yeah,
Oh,
it's
that's
the only
right.
other one. But this shows up quite often on some of the testing things, so.
mhm. You're gonna
What,
see
what
that
are
one a lot.
crystalloid?
Crystalloid and colloid,
Yep,
that used, or at least that's what they used to always question us about. And, you know, when you use a colloid type, and what is an example of colloid? Which one of the following is an example of a colloid solution?
okay, treating septic shock, use appropriate precautions, high flow oxygen, IV access, administer fluid boluses to maintain radial pulses. Start out with 250 or 500 milliliters depending upon the person. Patient size does make a difference.
They have a chart that describes how much IV fluid and what IV treatment for each.
They say 20 to 30 milliliters per kilogram,
Okay.
maximum.
But what I'm
dosage.
talking about is like cardiogenic shock versus, cause they've all been slightly different. TKO, you know, and maintaining greater than 80 so they've, in the last like 3 slides, they've given specific instructions for each type of shock and the IV treatment.
Well, why would you not want to run it wide open with a tension pneumo?
You don't want.
What's happening to the heart?
It's being
It's got-
compressed.
It's-
pressure.
Fluid around it is
Yeah,
pushing
you're-
down
all
on
you're
the
doing
heart.
is just
And
increasing-
it's already moving a low volume, so you don't wanna dilute the low volume that's already.
Yeah, and you don't want to add additional fluid to it to tamp it down. Going back,
Hang on, go back slower.
okay, sorry, I meant cardiogenic shock.
So what is it for cardiogenic?
It's
TKO.
TKO also.
And why is it TKO? What's the other reasons you have it for TKO? It's for the hospital.
Right,
Just,
for,
medicine
yeah.
access
So they
or
can-
medicine.
So they can give
Unless
meds.
they've got IV access, basically you're just speeding up the time.
Well, what's the best route of access?
IV.
IV. Then hypovolemic, where you don't have enough, that's where you're gonna wanna provide a
So it's
bolus.
a bolus, but maintain, is that the one that's maintain radial
radial.
pressure?
Yeah, at least 80 is what you're looking for. And there's like 20 to 30 milliliters per kilogram max that they talk about.
So on six
Oh, but that's a
seventy-six
ton.
London,
It can be a bunch.
20
Figure
to 30
100
milligrams.
and,
Yeah, if
let's
you're
see.
100 kilograms.
If you're a 100-pound person, 2.2 pounds,
Yeah,
kilogram
if you're
wise,
100
you're
kilograms,
like
you're 200
40 something, you'd be looking at 1,200 milliliters max.
Yeah, that's.
on page 676, they don't give exact numbers, but they identify which ones are TKO, and then like septic, maintain till radial pulses. maintained, so neurogenic, so they kind of tell you that.
Okay. What is it,
676.
When we first took the class years ago, it was either wide open or TKO. But there's been a lot of studies on fluid replacement. That has changed.
Neurogenic.
I missed that, Travis.
I said years ago, it used to be TKO or wide open, run flush. Well, what they found is that you can do some damage by running flush. It's even like the two IVs, if you start them in, if you got one going in this arm, one going in this arm, you're gonna give a 500 milliliter bolus, then recheck.
Cardiogenic.
Doesn't take long to run 500 milliliters with two IVs running wide open.
Yes.
Now, and we understand that majority of our calls around here are actually from scene to doors, actually fairly short.
Right.
Right, unless you're out in the canyon or you're out on Highway 120, sitting out there about the rest area.
Right, right. And so, but make sure you tell the hospital, all right, we've given this much.
Yeah.
And that, it's wide open right now, when you roll through the door so they can.
What else do you want to tell them? Do we have a radial pulse? Have we been able to get a radial pulse? That would be,
No, I found it in the book. Thanks to Ian.
you did find it? Does that help?
Yeah.
Let's see, what am I?
But I'm gonna have to be able to remember all of this.
Tension, pneumo,
It's crazy.
septic shock. Use appropriate standard for high flow O2. Gain IV access, administer fluid boluses to maintain radial pulses. So 250 or 500. What's going to make a difference between 250 or 500?
Person.
Size of the person. Bigger person, you might want to start with 500. Smaller person, you'll want to start with 250. Then what are you going to reassess?
Pulse.
Radial pulse
I thought you said wind.
or blood pressure. Radial pulse. If they got a radial pulse, what's their pulse got to be? At least 80.
Okay, go back on that. Pulse is at least 80 or pressure is at least 80?
Pressure.
Pressure is at least 80 if you've got a pulse.
Pulse, yeah.
At radial.
If you can feel a pulse, you've got at least 80.
Okay, so that 80 PSI, or pressure.
80 systolic.
Okay, that's what I'm saying.
Not 80
Because I
per
keep hearing
minute.
pulse, and I keep hearing things, I'm like, hold it.
Yes.
If you've got a pulse, radial,
Right.
a radial pulse, you've got at least an 80 systolic.
86.
And that's what if I've said that wrong, I apologize.
Well, no, several of us have said it both ways, so I just thought, we gotta clarify that.
We're just saying pulse instead of saying check the pulse.
pressure.
Okay.
Pressure,
Right.
yeah. And you should check pressure, obviously, and you're gonna be checking pressure. Neurogenic shock, maintain airway, obviously, spinal immobilization. Inadequate breathing is needed, conserve body heat, provide the most effective circulation possible. Anaphylactic shock, what are we gonna administer? Epi, what's the dosage for an adult?
Make sure you
3.
wrap the adult.
0.3.
3 and.
Get the adult dosage, obviously,
0.3.
Just 0.3 or 3?
0.3.
0.3.
I
And
just know there's a
0.15.
Child dosage is
I'll look at it and
0.15.
figure it out.
But do we have both doses in the ambulance? Okay.
Child on the left or.
And you do an MS1, MS2, you do not in 195.
195 is the old one?
Yeah. We don't keep it.
Not the one that says 195 on the outside.
No, not anymore.
It does.
No,
Oh, you
he-
fixed
Brennan
it.
fixed it.
No, I fixed it.
Brennan fixed it. Thank you.
I mean, the license plates are still wrong, but don't.
Well, we're one step closer.
Psychogenic shock, we'll talk about this when we talk about neurology, nervous system issues or injuries. Try to get
Psychogenic
information.
shock is, there's no recommendation for IV.
Yeah, and it's one that,
Yeah. That's one that they don't have a recommendation for IV.
yep, they don't. Treating respiratory insufficiency, immediately seal any hole in the chest. What kind of dressing would that be?
Occlusal.
Occlusive, yeah. Secure, maintain the airway, and administer supplemental oxygen.
Plastic.
What's the one that has a
Flap on it,
flap on it?
that'd be an
That's that
inclusive.
That's inclusive, isn't it?
Yeah.
Okay.
Did
That question was always on the test and always threw me off. I was like, well, no, it is public. I was thinking it had, inclusive to me means it's.
Well, let's put it this way.
It's inclusive.
If you don't put a flap on it and it works for a little while, you can always peel it back and then put it back down again.
Burp it.
Exactly. Okay, I'm done.
Okay. You wanna take a break or you want me to just jump into it?
Yeah, I wanna.
That was pretty damn good.
You wanna what?
You want a quick break?
Quick break.
Alright, go.
I'm on McDonald's.
It's gonna take us a while to get to Mark's presentation anyway.
Go.
Oh, yeah, that
Go,
big
muffin.
is
Go.
pretty good and twisted.
Yeah.
Hey, I got through the 4 feet of ice.
I tried to call you last night to find out if you.
7 o'clock is when I finally got through it. Well, 6:30 maybe.
What vacuum? I got a vacuum there?
Finish putting in these grades.
Mark from Milwaukee shot back.
Oh, oh, look at that.
And then I had
That's an
to-
old age run.
Then I had to tape a garden hose on the end of it.
No, just stick down there.
Yeah. I started just pouring boiling hot water down it with ice melt and beating the crap out of the key till it got down.
So was it frozen the whole way?
The last 6 inches wasn't, but yeah.
Really?
But then I got out of the shop at 10 o'clock.
Chapter.
Oh.
I like my computers working fast. My turn to go potty now. So what were you doing last night?
Yeah,
I had this water valve in the ground to turn on the water to my shop.
I got off of one
It's
job.
got an inch and
I
a
didn't get
half
off
pipe.
of the other one.
Some sidewalk slopes towards it,
Single carrier.
and they didn't Teflon tape the cap on or anything. So a bunch of water just ran in there.
Okay.
Yeah.
Go for it. I like it.
Pipes problem for us too, I think.
No, it was right up. So that's where they got down to the valve there.
You gotta pretend
When I
to feel
started
like
to the top of
like
that.
shower them.
No.
So they got it very deep.
You could try to get up and get over in the shower.
When I started.
Hilarious.
They want to eat up there, that's about it. Getting there, I think so, when he comes down the corner, he's like, "You know."
Yeah.
Why was your water flowing?
Actually, it was so funny because
See this?
I think Dad would have been
That's
better
about
with
6
me
inches
doing
of
it
water.
than Jerry.
It slopes. This stuff is all-
Bizarre, I don't watch it.
It was always funny though. It was Jerry and Jerry. And so when he was presenting for Jerry, which I
Didn't read that book?
No? My bad.
This computer is
yeah, that looks like so much fun.
It is. This is the more fun part. There's worse,
Just entering it.
there's worse parts of this.
I'm sorry, is Danny under last?
Oh, that would be frustrating.
Nothing at 0. I'm surprised. I'll have like 5 with no names, and I'll have like kids come in, and I'm like, "There's a pile of no names." I'm like, "Yeah, mine's not in there." I'm like, "Okay, guess you can do it again."
It's gotta be in there.
Yeah.
Oh, you're.
No, I don't recognize the handwriting.
That's funny.
You written the grades on top of your report. Yeah, I did.
Right click it.
You'd be like, yeah, okay, this is mine.
Right, I searched through the file, find an A, and like, this is me!
See, it's focus slides, chapters, no, if I can, right there.
videos,
That's good.
at least, it's like,
Oh,
thank God.
I know who it is. There's only one kid who's taken the test. On my list. Not do well. Reaction rate and chemical reactions, equilibrium.
So I just took an exam.
That's chapter 14.
I just took an exam over that.
Good job.
Yeah.
How'd you do?
Down
Yeah,
at
17.
My chemistry professor was like, yeah, we can see it like eventually.
This is the lowest grade I've had at this point in the semester before.
Oh, yeah. You need to go kick his butt?
If you can find him,
I freaking logged him into.
I know. I mean, he's a good kid. I haven't seen him for 3 weeks.
If I see him, I'll yell at him for you.
Good. I think
Not
he's
that he'll
still
listen to me, but
works at
How long do you want me to wait?
And I'm like,
I never go there. I never go there.
he comes to first half of the day and then just leaves. And I'm like,
So capable if he would just apply it. That's what's so hard. I told him, I'm like, I get to rally with you, not just to be growly, because you can do so much more. And so when you come to my class and you give me an answer like that when I know you
That's
can
the
do
fourth.
significantly better, I get grouchy and just say,
Wow.
don't come in and be lazy.
We got somewhere,
Don't do me any favors in life.
finally. It's a little slow, is it?
You're right, it
I made him
sucks.
stay in at lunch the other day. He's just
'Cause
copying the
first-
the board. and
first
he's
I did
capable,
right
but
through it.
Writing is hard, spelling.
No,
is
I'm not
hard.
feeling so bad
But you're
then.
copying words.
I've lost
so
my
I
book.
do it. And then the next test,
I did.
he did, he's right.
What'd you take right here?
Don't you ever try to teach me again, because that's good, I mean, for him, that was outstanding, like,
Wow.
Yeah, that's what I said too.
you take your time.
Got it.
Hey, London, they might need some of your
Because I would
magic
have him
over
like,
there.
come and give the test to me, take
It's
the
not-
test orally, cause I
responding.
couldn't begin.
It's
to
not
say
letting
it
me
was writing.
respond.
Like, yeah, that's never happening again.
I was
Oh,
in London for the
cancel.
last, Connections, they have not been doing like live lessons at all. I think it's crappy because y'all were doing live lessons, you know,
It takes
like,
forever.
Well, I mean, it's
we're so.
part of how when you interact with kids, you gotta.
I'm just
they
trying to close
make
He's
it
just
better.
trying to turn off
Even if it's not related to science, I'm gonna tell
the
you.
PowerPoint.
Right.
95
Well,
things
so
that are running.
They haven't been like out.
That I don't know. I only opened one, I swear.
And so this is one that's hard to like.
So go back up to that.
It was
you know,
super
and
slow when
like
it started.
teacher books or anything, so it's like,
Yeah, yeah.
so I've been taking school pretty much with her. But finally, the algebra teacher has started doing, at least a video for every lesson.
Oh, you said live lessons, not life lessons.
Yeah, live lessons,
Live.
like, they weren't.
I do life lessons too.
Well-
Shower regularly, assuming.
Some-
Well, they're not mowing
Some-
technically, they're my last year's.
She misses, Miss Townsend being one of her teachers.
2 years
She was
ago.
an English teacher and,
Oh, online? Yeah.
Hey, since we've got everybody here, the next time we meet, I thought we'd start through these practicals, doing those as a catch-up deal. I kinda wanted to do it today, but I had so many people I thought were gonna be gone, I kinda backed off of it.
Yeah.
But I think it wouldn't hurt to go through and run these a few times.
Agreed.
Agreed. And I was noticing on the IV, I think we've gotta hook it all the way up, so.
There is,
Waiting to.
I'm
Okay,
gonna go
go.
to chapter 17 now.
Here. So they can see that. Can they see it?
Yep.
Then they got that. Do you want me to read it out loud again?
No, we can read.
This is kind of a,
Go for it.
alright. Respiratory.
Upper,
I
lower,
like the-
got it.
Alright. Respiratory is the upper airway and lower airway. So what's the dividing point? Anybody remember?
You're,
Bronchus?
Upper would be like windpipe.
Trachea.
No.
Trachea.
What is considered the, this one might be on the larynx.
Larynx.
Larynx is the dividing point. Anatomy, physiology, pathology.
Epiglottis is part of it. It says right here. Go for it.
That is the upper airway?
Yeah, part of it.
Okay. Yeah, alright, never mind, that's fine.
You got
So,
it.
pathology assessment and management of the epiglottis, spontaneous pneumothorax, pulmonary edema. Example of pulmonary edema is what?
Swelling in your lungs.
Swelling in your lungs, which is the most common thing we see? COPD. And asthma. All right, anatomy, physiology, pathology. You got chronic obstructive pulmonary disease, which is
COPD.
one of the most common things we see around here. Environmental, industrial exposure.
Asbestos.
Asbestos, what's the one we worry about most around here?
H2 gas.
H2S.
Falling naked.
Falling naked, that's right. All right. Lung concerns, all right? Respiratory concerns, all right. Toxic gas, I guess that would be the H2S, would it be?
Or
In the middle
Pertussis?
school, that's always a problem.
carbon.
What's an example of pertussis, any idea?
Whooping cough.
Whooping cough, okay? And cystic fibrosis. And what is cystic, anybody know what cystic fibrosis does?
The extra
Chronic.
crap in your lungs, so there's like extra phlegm
Gooey?
and crap.
Crack.
It's kind of gooey lungs, yeah. Right, is that the best way to, that's why we're gonna do it, all right. Anatomy, physiology, pathology assessment, management of the pulmonary embolism, of pneumonia, viral respiratory infections, and obstructive restrictive diseases. All right, dyspnea is what? Difficulty breathing. Common complaint, symptom of many conditions. Keep medical problems in mind as you obtain history and perform the assessment. And of course, to treat the symptoms, underlying problem, and anxiety. You're gonna see dyspnea in COPD patients. How do you treat it? Low flow oxygen. Don't go over how many liters? Huh? You guys remember? On COPD,
Is it 10?
6.
Low flow, so not over.
However, if you got them at 6 liters and they're maintaining only 83%
For transport.
SPOT, and you've got a ways to go, can you increase it with the mask?
Yes, temporarily.
Yes, you can, but you have to be ready to be able to bag too, in case they stop breathing. So that's just an example of that stuff. All right. Upper airway. All airway structures above the level of the vocal cord. See, I told you. You guys,
You said larynx.
did I see larynx?
Larynx. You said
Son of
larynx.
a
I said
bitch.
epiglottis, I was wrong.
Oh,
You're right.
I don't normally cuss.
Yeah.
God darn it. I meant vocal cords. Dang it. All right, I'm gonna miss that on the test. All right. Gas exchange. Blood in the pulmonary circulation picks up oxygen and releases carbon dioxide. So, do you guys want to go over this real quick?
What is the upper airway?
The upper airway is pharynx, mouth, epiglottis, larynx. I thought the tongue was considered part of it, though. Not necessarily.
Good
Well,
to mention, but anyway.
It's
Lower
in the
airway.
airway, but it's not.
So the
part of
lower
it.
airway is going to be
You
your
can
trachea,
still breathe if they cut your tongue,
bronchioles,
right?
and main bronchi, and of course the alveoli. What's that? What did you say?
Says you can still breathe if they cut your tongue out. So I guess it doesn't count.
That's right.
All right. Most of you guys, what's that? You got that? You guys want me to go over any of this? You good with that?
Good with it.
All right.
This is a long chapter.
Yeah. Anatomy and physiology review. I encourage you guys to read that. I can go over it with you. You got your blood exchange, your capillaries inside the lungs, the alveoli, which is here, and out here in the tissues, you're at the capillary level. Okay? So, and we're dealing with also, obviously, your nasal cavity, child's tongue, adult's tongue, remember that
Proportionally different.
proportionally different. Okay? Any questions on that? Good. All right. So, 2 processes occur during respiration: inspiration and expiration. Ventilation is the process of moving air into and out of the lungs. Heart pumps oxygenated blood throughout the body. Carbon dioxide is exchanged for oxygen in the lungs. Here's a little bit more close detail showing the transfer of oxygen and carbon dioxide into blood cells. Questions?
Diffusion
Nope.
is the key part.
Perfusion. yeah.
Perfusion is what that's called. All right, inspiration. Inspiration.
Inspiration.
Just inspiration.
Diffusion.
Stimulus to breathe comes from respiratory center in the medulla. The medulla. Where's the medulla? Anybody know?
Your brain.
Isn't it in the back?
It is. Where's the medulla, Amy?
Oh, I don't know.
You know this. You teach this stuff.
I
Medulla.
don't teach this stuff.
Our poor children.
Is it the,
It's
is it the
the-
little block? No,
It's
that's
the
pons.
lower portion of the brain that controls all function. So if you have a head or neck injury at the lower portion, one of the things you've got to worry about is the medulla, because if that gets damaged, you're gonna
Bless
have
you.
you're gonna have severe problems maintaining circulation, insulin, inspiration.
Yeah, you're right. Okay.
Yeah.
I don't know.
The medulla oblongata.
Something's wrong with his medulla oblongata.
That's right. That's right. I was hoping someone would catch that.
See?
What?
Something's wrong, it's from water poisoning.
Oh.
There's a reason that alligators are aggressive because they have all those teeth.
They don't brush them.
Huh?
And they don't brush
And they don't brush them. It's a movie. You gotta get out and watch TV more often. Alright. Diaphragm and the intercostal muscles contract. The thorax enlarges and interpulmonary pressure fall below atmospheric pressure. Air fills the lungs. Okay, so in other words, you're taking a breath in and it's actually sucking the air in when you're with your intercostal muscles, diaphragm, and all that crap. Okay? When the pressure outside the thorax equals the pressure inside the thorax, inhalation stops. Does that make any sense?
Yep,
Anybody have any questions on that?
but it's your intercostal muscles are relaxed while your diaphragm is contracting, and then they reverse. Cause your intercostal muscles relax, which allows when your diaphragm moves, or allows your chest cavity to get bigger.
It says diaphragm and intercostal muscles
Together?
contract.
Yeah, so your diaphragm contracts pulling it down, but then the intercostals contract pulling your ribs up and out.
Up
I
and
thought
out.
it was interesting in the aging chapter, the percentage of, I don't know, how
Oh.
much elderly intercostal muscles lost their strength. It was a significant amount, which is why.
Yeah, I remember, yeah.
Breathing
Yeah.
easier.
Okay, so as the chest expands, receptors send a signal to the
It was like 50% weaker.
I watched my dad.
well, whatever that word is.
That's a lot of work.
apneistic center to inhibit inspiratory center and expiration occurs. Prevents overexpansion of the lungs. Expiration lasts twice as long as inspiration. By the way, I timed it, it did not. I
Now,
was just
Brewer
curious.
reflex is what you're referring to.
Well, the what? What's it called?
Herring Brewer reflex.
Herring Brewer reflex. Why don't they have that in there?
It's in the book.
I know, but it's not here.
It's like in the next slide or two, I think.
Adequate ventilation, diffusion, and perfusion must occur for body to receive nutrients and oxygen. Complications interfering with oxygen intake. Upper airway obstruction, lower airway obstruction, chest wall impairment, and neurologic control problems, which would be attributed to medulla oblongata. It's all about the medulla. Remember that. In a way. Okay. Alveoli are made up of two types of cells. Type 1, pneumocytes, okay. Type 1, allow for better gas exchange. Type 2s make new type cells and produce surfactant. So that'd be like your phlegm, right? Is that gonna be phlegm?
Something that, reduces surface tension.
Yeah. Alveoli function best way partially inflated. Or best when partially inflated. Surfactant reduces surface tension of the alveoli, making it easier for them to expand. Oh, so it's basically lubricating the
It's
tissues.
like a lubricant, yeah.
It's like a lubricant.
So that's one of the issues with, what were we talking about, the chronic disease that fills your body with lungs, their surfactant level is lower. Keep thinking multiple sclerosis, but that's not it.
Oh, cystic fibrosis.
Cystic fibrosis.
Oh,
their
that's
surfactant
example,
level is really
okay.
low, and so they can't clear out their,
Crap.
yeah.
Conditions related to the ventilation and or perfusion can prevent oxygen from reaching the bloodstream. People with chronic lung disease make a surplus of red blood cells, making blood thicker. Cor pulmonale, right side heart failure because of chronic lung disease. So, carbon dioxide retention and hypoxic drive. So, the rise in the arterial carbon dioxide levels leads to less efficient respiratory center. Result of chronic carbon dioxide retention. Hypoxic drive, which is what? You guys remember what hypoxic drive was?
CO, carbon dioxide level.
Is it carbon dioxide or
Low,
oxygen?
hypoxic is
Low
low
oxygen.
Low oxygen.
That's on
Oh.
COPD.
So it's driven by your oxygen, yeah. Backup system used to control breathing based on low levels of oxygen rather than high levels of carbon dioxide.
That's exactly what Tyler just said.
He did say it very loud.
Well, I was not-
Yeah, I always say that I said that too, even.
No, he said it word for word.
Did he? But did he say stimulus to breathe, the detention of low blood oxygen levels? I didn't think so, because I didn't hear it say that either. If it wasn't said out loud and it's not documented, it wasn't said according to.
The first half was documented.
Oh, okay. Oh, good point. I'll give you that one.
Normal is hypoxic.
Hypoventilation, which is low ventilation, right? Hypo, low. Okay. Excess on carbon dioxide in blood results in respiratory acidosis, can occur if hyperventilation is not recognized or carbon dioxide level is directly related to pH. Causes of hypoventilation: impaired lung function, impaired mechanisms of breathing, impaired neuromuscular apparatus, and reduced respiratory drive. Questions on that? Continuing on with hyperventilation. Arterial carbon dioxide falls below normal, may be an indicator of life-threatening illness. In our ambulances, you won't know that because we don't have the,
Until my birthday.
Until James's birthday.
yeah. Oh,
Capnography,
capnography, there you go.
Capnography.
or capnographer. You want me to send you a link?
Oh, please do. All right, tachypnea, rapid breathing. Because everybody recognizes tachy, right?
Yeah.
All right. Without physiologic demand for increased oxygen causes respiratory alkalosis. An example of that would be what? Hyperventilation. Hyperventilate. How many of you guys seen one of those so far? Most everybody has. That's kind of, and so that's leading to respiratory alkalosis, right? Okay. Alkalosis causes symptoms of hyperventilation syndrome, giving the body's response to illness and a buildup of acids. Causes of dyspnea, which is shortness of breath. One or more of the situations must most likely exist. And I'm not sure what, you guys remember what that one is? Acetostasis? Acetostasis? Any idea what that one is?
Yeah, I'll look it up.
Complete or partial collapse of the entire lung or area of the lung.
Oh, okay. So, why did they just say, okay. Telostasis, collapsing of the lung. Damaged alveoli, obstructed airway passages or blood clots, pleural space filled with air or fluid. Patients with dyspnea may also report air hunger, which is gasping for air, chest tightness. Why would you have chest tightness? Any ideas? What are some reasons why you might have chest tightness? Fluid in the lungs, excessive breathing, trying to get it. Pneumothorax, right? Okay. Dyspnea is a common complaint in patients with cardiopulmonary disease. Severe pain can cause a patient to experience rapid, shallow breathing without pulmonary dysfunction. Upper or lower airway infections. And obviously they're different. May cause dyspnea by obstructing airflow in larger airways, may impair exchange of gases between the alveoli and the capillaries. All right, acute pulmonary edema. Accumulation of fluid in the lungs. It causes decreased gas exchange, severe dyspnea, fluid collects in the alveoli and lung tissue. Not all patients with pulmonary edema have heart disease. Patients with pulmonary edema may also present with dyspnea, orthopnea, which is what?
Can't breathe laying down.
Can't breathe laying down. Fatigue, reduced exercise capacity, oh, that explains me, and pulmonary crackles. I'm gonna note that, I've got acute pulmonary. All right, chronic obstructive pulmonary disease, COPD, common around here. Slow process that disrupts airways and alveoli, usually due to cigarette smoking, is the most common cause. Obstruction occurs in the bronchioles. Chronic bronchiolitis results from the overgrowth of airway mucus glands and excess secretion of mucus. The pneumonia develops when passages are consistently obstructed. Repeated episodes can lead to COPD. Oh, pneumonia develops when passages are, okay. Emphysema, most common for COPD, characterized by destruction of alveolar walls related to destruction of pulmonary surfactant. So would that be?
For cystic fibrosis?
Similar to
Yeah,
cystic
but
fibrosis?
Yeah, cystic fibrosis is their tissue, their fluid is has less surfactant, so it doesn't become removed. So they have to do like physical therapy to like break up. They're like if a leg slanted
right.
and they have to get like pounded 3 times a day or something.
So that would be similar then, right?
Well, it's a symptom of both.
Yeah, okay. All right. Patients with acute COPD will complain of shortness of breath and gradually increasing symptoms over a period of days. They exhale through pursed lips. Complain of tightness in the chest and constant fatigue. Have a chest with a barrel-like appearance. Again, that's so would they still be using the diaphragm muscles as much? I can't remember if they would or not. Okay, chronic obstructive pulmonary disease. That gives you an idea. There's a normal lung, inflamed, and then obstructive. I can go back if you need to. Acute spasm, dealing with asthma, I'm sorry, which is an acute spasm of the bronchioles. Excess mucus production and bronchial bronchial muscle spasm, combination of bronchospasm, mucus production, and edema. Here they're showing you normal lung and the narrowed. Results from allergic reaction, exercise, severe emotional stress, and upper respiratory infection. Anaphylactic reaction, which is severe allergic reaction characterized by airway swelling, upper or lower. Could be either on those. It's not. Dilation of blood vessels all over the body can cause respiratory distress severe enough to lead to coma and death. Most reactions occur within 30 minutes of exposure to an allergen. Spontaneous pneumothorax, accumulation of the air in the space, may be caused by trauma or medical conditions. Diminished breath sounds on affected side. Has most everybody seen one? I haven't seen a spontaneous one. Have you, Jim? Oh, he's playing.
Tall, skinny person.
Spontaneous pneumothorax?
I don't think I've ever seen an actual spontaneous one.
More common in tall, skinny males.
You know, I'm
Is it-
sure we
it's
probably
more-
have, we just probably didn't know it. I mean, to guess we've
Yeah.
seen one,
See,
but
that's why I keep the weight on.
especially with some of
Fixes
our
the problem.
elderly.
I don't wanna take the chance of a spontaneous pneumo.
I would guess with some of our elderly population, we probably had some, we just didn't know it.
Yeah. So patients become acutely dyspneic and typically complain of pleuritic chest pain, severe findings of altered mental status, cyanosis tachycardia, unilaterally decreased breath sounds, local hyperresonance to percussion. That's when you're tapping, right? Yeah, when you're tapping. Subcutaneous emphysema, tracheal deviation, which is a late sign. Anybody remember what's causing the tracheal deviation?
Backup of flow.
So if your trachea is off to the left, so if it's shifted over to the left,
Tension pneumo is on your right, right?
so your tension pneumo is going to be
Yeah.
on your right. And why is that?
Isn't it just pushing all of your organs over with that?
It's pushing
here?
everything that way. Usually it's a buildup of either fluid or air, and it's pushing it all that way. So that's why if you see a deviation to the left, that means it's on the right. If it's a deviation to the right, it's on the left. All right, pleural effusion, collection of fluid outside the lung on one or both sides of the chest. Fluid may be from irritation, infection, or cancer. Should be considered in patients with lung cancer and shortness of breath. You'll hear decreased breath sounds over the region of the chest where fluid has moved the lung away from the chest wall. Patients usually feel better when they sit upright. Definitive treatment is fluid removal. Do we do that?
Nope.
No. Well,
You send them
technically,
somewhere else.
technically, if they cough, if they cough something up, you can remove that. In a Kleenex.
They're doing chest tubes and that.
Like,
We have a camera for that.
it's not sanitary,
I was
but
gonna
well.
say, you're using it for the sewer as well.
Yeah. The one you were using to look inside the bird's nest the other day?
Are you that worried about it?
Yeah. Pulmonary embolism, which is blood clot circulates through the venous system and travels into a pulmonary artery. Caused by a clot formed in a leg vein or pelvis is most common, decreases or completely blocks blood flow.
My sister just had one of those.
I'll tell you what, when you see your first one, holy crap, you're just like scratch your head trying to figure out what the hell, I'm doing everything I can to get an oxygen. Yeah, my first one was like, what the hell? And he finally just sat up and he looks, he says, you gotta help me. And we're like, holy crap. And he didn't make it.
Fortunately, my sister is still with us.
This guy was post-cancer, or he's a cancer patient that was,
Should have
In
taken him to the
stages.
hospital and didn't.
oh, we did. Oh, no, he was in the hospital, then he sat up and looked at us. And I was just like,
Sorry.
so, no. May ossia, I see what you're saying. Well, funeral home kicked in here, I see what you're saying. Okay. Pulmonary embolism may also occur as a result of damage to the lining of the vessels, hypercoagulability, in other words, overcoagulating,
Yeah.
slow blood flow in a lower extreme. Would you think to see this thing in somebody that's getting blood thinners? Most likely, you wouldn't think you would. So, slow blood flow in a lower extremity. People that have been traveling is a perfect example of that, and they've been sitting for long periods of times on planes. That's one of the things they watch for. So, risk factors include mobilized legs, recent surgery, pregnancy, oral contraceptives, infection, cancer, sickle cell anemia, prolonged inactivity, and being bedridden. Signs and symptoms are going to be dyspnea, tachycardia, tachypnea. Jeez, it just covers either one of those, doesn't it? This is the one I saw the most of when we see it. It's tachypnea. I mean, they're just breathing up a storm. Varying degrees of hypoxia, cyanosis around the lips, acute chest pain, and hemoptysis, which is anybody? Amy's got it.
Blood.
No, I don't.
Spitting up.
Something. Coughing up blood.
Yeah.
Yeah.
Coughing up-
that
coughing
would
up
be a
blood.
Good way to break that down, think it through.
Yeah, I got the hemo. I couldn't think with the.
Yeah, it's,
All right, patient with dyspnea or obstruction of the airways. Patient with dyspnea may have a mechanical obstruction. Food is the most common. Tongue on an unconscious patient is not uncommon. So, in an unresponsive patient, this may be the result of vomitus, foreign objects, or your tongue blocking the
Which
airway.
one's the most common? Because that question was in here.
The
Like,
most common is
I said Tom did. I think I
in a
did.
conscious patient is food.
food in an unconscious patient.
Unconscious is your
It's
tongue.
I think it was unconscious of it, was tongue the answer.
Mhm.
Yeah, I can't do anything here. A couple
Um,
times.
Section 4, question 3, the most common airway obstruction in an unresponsive patient.
You're gonna be your tongue.
There's one more somewhere else.
Environmental industrial exposure.
I thought, at least.
Things that are included in this would be pesticides, cleaning solutions, chemicals, chlorine, and carbon monoxide. Amount of damage largely depends on the water solubility of the toxic gas. Highly water soluble gases can cause swelling and irritation. Less water soluble gases may cause pulmonary edema up to 24 hours later. So chlorine is gonna be less water soluble?
No, I think it would be.
Or would that be more water soluble?
Well, they put it in pools all the time.
So that's water,
Yeah, it's water soluble. I mean,
but it's one of, I know it's a really deadly gas, so.
Yeah,
If it's a
that's
gas.
it's gas, but.
Okay. So, all right. Cystic fibrosis, here we go. Genetic disorder that affects the lungs and digestive systems. I didn't know it got the digestive system. Symptoms range from sinus congestion to wheezing and asthma-like complaints. Look for respiratory insufficiency signs of respiratory infection and intestinal blockage. Often causes death in childhood.
Yeah, life expectancy is like 21. I mean, if you get past
Yeah.
21.
I had one kid I went to school with, he actually made it to 35. Remember Bobby Reich? Don't you? No, he was gone by the time you got here. Never
If
mind.
you make it to adulthood, it's currently about 44 years old.
If you make it,
To adulthood.
yeah, I think they say he died at 35 or 40, somewhere in there. Bronchiolitis. Age-related conditions. Bronchiolitis, inflammation of the bronchioles due to viral infection caused by metapneumonia.
Metapneumovirus?
Oh,
Virus.
metapneumonia virus and respiratory syncytial.
RSV.
Yeah, I'm not familiar with RSV. Are you guys?
It's a.
Respiratory
I've heard
syncytial virus.
Respiratory,
Breathing passages.
For children.
yeah,
It's very common in.
it's common.
Yes.
Asia?
Highly contagious, can be spread through droplets.
It was
Okay.
rampant in Asia.
So, croup, which is due to inflammation and swelling of the pharynx, larynx, and trachea, often secondary to acute viral infection. Hallmark signs are stridor and seal bark cough.
I don't have any experience with that.
Yeah.
This
Is
week?
Tyler Croupy?
It was, Logan was the one when he was little that we hauled him on the ambulance because of croup. They both had it, but Logan thought it was.
I'm perfect, so.
People had it, but they weren't.
Oh,
You know, it's interesting.
Some people are like, yeah, he's probably.
that one's your slow child that didn't get enough oxygen, right?
Tyler's was never quite as bad as Logan's.
Is that right?
He spent several days in the hospital a couple of different times.
Remember, we've hauled a couple of kids with bad croup, and it seems like if it's cold and you walk outside,
And they'd get better.
and they would get better, yeah, as we go in the ambulance. I mean, I've seen that several times with some of the really croupy kids. that we've hauled.
Actually, when Brennan was growing up, we lived in San Francisco at the time, and that's what our pediatrician told us to do
Yep.
when he got
Put 'em
that.
outside.
Is we just take him outside. Of course, out there's a lot of moisture in the air, and
They walked me in the backyard like a dog.
We put up a tent in the living room with a humidifier.
They'd put a
in
pork
it.
chop around your neck so the dog would play with you.
Better than the tent at the hospital, because I didn't fit in that bed very well, but I would get there. I'd crawl in the crib with
that
him.
dog used to drag him around the yard for hours, and he just loved it.
Explains a lot.
I hit my head on a lot of things.
Yeah. Okay, epiglottitis. If you ever want to watch a doctor panic, That's the one. Those doctors, when they suspect epiglottitis,
Cause that would be something that even like intubating is difficult in that
Mhm.
situation.
they're gonna be on the phone, they're getting that kid out of there immediately.
That's the one time you don't wanna make them cry.
Yeah, inflammation of the epiglottitis, or epiglottis, usually caused by bacterial infection that produces severe swelling flap over the larynx. Patient will appear very sick. Symptoms include sore throat, high fever, stridor, high-pitched inspiratory sounds, tripod positioning, and drooling. Or in other words, COVID. Jeez.
No.
I'm sure COVID's part of that too. So, but that is really one of those that I don't think I've ever seen it. I've watched a couple doctors where we brought them in, they thought that's what they had. And oh my goodness, those doctors were just like, I want Lifeline on the phone now, I want this doctor on the phone, telling this patient's gonna be there shortly, be ready. And then they get the word back, no, he just had bronchitis. So it does present very similar to bronchitis. Age-related conditions, pneumonia, ventilation disorder caused by an infection of the lung, parenchyma, there we go. Young children and elderly are greatest risk. Presents as a localized infection in the lungs, can become systemic. Signs and symptoms include fever, chills, productive cough with purulent, sputum, pleuritic chest pain, and excessive mucus. Pertussis, highly contagious airborne bacterial infection, most commonly seen in children under 6. Cold-like symptoms, but coughing spells can last up to 10 minutes, more than a minute. Oh, I thought they said 10
I
minutes.
pulled some serious muscles when I did it. I hurt so bad. When I had it, I was really sore.
Is that right?
I pulled muscles and.
Oh, yeah. Feverish with a whoop sound on inspiration after a coughing attack. With a whoop sound on inspiration. Oh, okay, all right. Airway obstruction. Always consider the possibility of foreign body when a young child becomes short of breath. Tonsil inflammation may be partially occluded airway. Dysfunction of a tracheostomy may create an upper airway obstruction. Obstruction may be in the lower airway, tracheal trauma, lung disease, mucus, smooth muscle spasms. Heart failure. It sucks. Heart muscles injured by the heart illness results in pulmonary edema. Risk factors include hypertension, history of coronary artery disease. Signs and symptoms include difficulty breathing with exertion, sudden attack of respiratory distress, feeling suffocated, cold sweats, tachycardia. Wet lungs versus dry lungs. Wet lungs are associated with pulmonary edema, dry lungs are associated with COPD. So, how do you check to see if it's wet lungs?
Is it just going by sound?
It's gotta be,
Yes.
because I'm sure we can't swab it. But, yeah, it's gotta be, breath sounds are helpful, but can also be confusing. Treat the patient, not the breath sounds. Well, shit.
Then why do we need to know this?
That's exactly it. What the hell? Scene size up. Determine the number of patients, determine the nature of the illness, identify need for specialized resources. So if you've got multiple patients in an area that are experiencing the same thing, what should you suspect?
Carbon monoxide?
Something airborne.
We were told a terrible story.
And so what should you be doing?
Scene safety.
Backing off and letting the fire department do their job. Wait till they tell you it's good to go.
Sensors for that.
Scene safety, that's exactly it. Primary survey. Recognition of life threats and initiation of resuscitation take priority. Signs of life-threatening respiratory distress, severe cyanosis, absent or abnormal breath sounds, audible stridor, dyspnea, coughing, tachycardia, abdominal breathing, change in respiratory rate or rhythm, pallor or diaphoresis. What's paler?
Color.
Is that their color? Pallor's color, okay.
Yeah, so pale,
Diaphoresis is
sweaty.
sweating, okay. Use of accessory muscles, tripod positioning. Anybody not know what tripod positioning is? A couple of those guys are doing it right up there. They just don't realize it. It's kind of. All right. Note general impression of the patient. Determine if airway is open and clear. What's the easiest way to know if their airway is open? If they're talking to you. Determine if the patient is breathing. Provide appropriate oxygen therapy. So if they've got an SaO2 on your monitor of 91, you're probably good, but you're not. Are you going to hurt them with a cannula?
No.
Depending on what you're treating them for, if you think they could be going down pretty soon, then go ahead and put that oxygen on.
It's about a minute behind.
Yeah.
That's right.
Oh, that's right. I forgot about that. Your SaO2 is a minute behind. Okay.
45 seconds to a minute behind.
Not with our equipment. It's more like a minute and a half.
Until my birthday.
Yeah, to you. When is your birthday?
April 30th.
And things are gonna change then?
Can I have a IV warmer for my birthday?
I can put in for it.
Cause it comes under the hood of the ambulance.
That's what I'm thinking.
I have to shove them down my shirt, and that's not very pleasant.
TMI.
You know what? Why do you constantly shove stuff down your shirt?
I'm trying to warm it. I have a warm body.
Thought you were trying to fill the void there, but. Sorry.
I think, you know what, maybe the ambulance will just invest in some, never mind. I won't say.
Yeah, just move on.
You're on YouTube.
I'm on YouTube, so that could be wrong.
Yeah, I didn't say that.
And since I did not finish that sentence, it doesn't count. So, primary survey. Identify any life threats in your patient. Problems with airway, breathing, and circulation. Poor initial general impression. Altered mental status. Potential hypoperfusion or shock. Chest pain associated with low blood pressure. Severe pain anywhere. Jeez. Excessive bleeding. Assessing breath sounds. Oscillating breath sounds. Listen over bare chest. So, majority, I don't know about the majority of you guys. I'm good about doing the front ones. I am not good about leaning them forward and checking the back.
Yeah, I will do the sides, just
Yeah.
because it's easier to get to them, but I don't do a good job with that either.
So, that's something that we should try to get used to, especially when you're en route to the hospital.
Shay does a great job of that.
Who?
Shay.
Does she?
She's
Good
got
ears.
it down.
Because you got great ears.
Essentially every patient we have.
That's good.
You know, my problem is once the ambulance starts to roll,
I can't hear.
I can't hear it.
That's when you just like zone out.
I can't hear as it is.
I hear the rumble from the ambulance when I
You
mean,
get
I,
those amplifying
Stop
electronic
teaching,
ones.
'cause I
I
can't.
can hear you guys perfectly fine in front
That
of
would
me.
be nice.
I also
yeah,
have
well,
like a
it's just trying to listen through the stethoscope and hear breath
$300
sounds
stethoscope.
when we're moving. It's
Oh, well,
tough.
that probably helps.
And I have a good stethoscope. It changes the sound for me a little bit.
Right.
That's the last time. Well,
So-
every stethoscope is falling apart.
Determine whether the breath sounds are normal or abnormal. Abnormal breath sounds include crackles, rhonchi, which is what? Do you guys remember what rhonchi is?
Kinda, I don't know, I
Kind of like,
feel
like
like it's
fluid.
a harsh sound.
I see
like
these.
forced
I see
air.
these ones right here on tests. Is why.
Uh-huh.
So rhonchi. You remember what rhonchi is?
I'll show you.
Turn it up.
I'll play them for you.
This is unforgettable.
That's it.
Okay. So if you hear music in the chest,
In this video, we're going to discuss differentiate.
rhonchi is what? A snore. I thought Strider was
Ooh, here
snoring.
it is.
Can they hear this?
Gurgling.
They're not gonna be able to hear.
Gurgling, yeah.
Yeah, that's
Gurgling
kinda like-
noise? Oh, gurgling, okay. It does sound like a gurgling, doesn't it?
Here's Strider.
And this lung sound different as high pitched, almost like a whistling sound, because it's more commonly seen in them. They can produce it with this.
So, we're listening to breath sounds for those of you
Strider's
intensely.
lung sound is that it's going to require medical intervention.
I'm getting pretty fed up with the BS right now that's going on. This beef, we're gonna discuss the wrong guy.
Is that Strider?
Yeah.
Yeah.
Holy crap, I can tell a lot of difference.
You couldn't?
There was a-
God.
Much higher pitched. And they're on like inspiration.
It's a higher pitched gurgling?
No, this is kind of a sweet.
Oh, there I can
Yeah,
hear it.
it's sweet.
Kind of sounds like an owl.
It's in the bronchi.
So,
Yeah.
bronchi is considered a snoring sound?
Yeah, bronchi is,
Bronchi.
it's in the bronchus.
Okay. So, for those guys in 10 sleep, where are you guys getting that from?
YouTube.
YouTube? So bring up YouTube. and
Becky
look-
just texted me, they're getting it. I mean,
Okay, all right.
They have it.
So Strider, wheezing. Wheezing's the most easiest one for me to hear. Pleural friction rub.
That's gonna be the
It's a
lungs rubbing on the side of the
It's a
pleural
rubbing
space,
sound.
but I have no what.
I feel like I've had it. Like I'll take breaths and I can.
And then of
feel
course
it.
snoring sounds is the last one.
Let's see if I can find it.
Heard it. What day
Oops.
was it? Thursday?
Pleural rub. Here's a pleural rub.
Pleural
I'm
rub.
doing this video right now to give you a gift. So
Thank
what
you.
I've done is I put
Appreciate
together 32 of my
Yeah.
Pleural friction,
Very coarse
two thin
sound,
layers
very
of tissue.
noticeable sound, and typically it's only in one place. Reasons you can hear pleural rub sound.
Oh, it's in one place?
would be things like pulmonary embolism, pneumonias, or anything that is going to have inflamed surfaces in the lungs sliding against one another. That's the cause for that sound, is that sliding.
There you
Oh, it sounds like they're moving furniture. Seriously, that's what it sounds like to me. Okay, so like moving furniture would be pleural friction rub. Okay, then snoring sounds. All right, history taking. Sample history can be obtained from the family or bystanders. Limit questions to pertinent ones. General state of health, their childhood or adult diseases, recent surgeries or hospitalizations, traumatic injuries or chest pain. Ask about previous episodes, medication allergies, current medications, that kind of stuff. Pay close attention to the medications the patient is currently taking. Use OPQRST, which stands for
Onset, provocation, quality,
Radiation, symptoms and time.
symptoms and what?
time, how long.
And then the I.
That's only for the eye aspect.
Intensity? I don't know.
No, it's,
It's, I can't, there is OPQRST dash and the I is, it's not,
S is severity.
oh, severity? What, okay.
Yeah, how se-
Interventions, what has been done?
Interventions, okay.
Interventions.
Prior to
Interventions.
when we got here.
Interventions, that's right. What have they done before you got there? Such as taking a inhaler. Mnemonic to determine the specifics of the pain, obtain information about the breathing problem. All right, chronic respiratory conditions. Chronic lower airway obstruction makes it difficult for patients to breathe deeply enough to clear the lungs. If a new infection occurs in a patient with COPD, arterial oxygen level may fall rapidly. Patients with asthma may have different triggers. Try to determine what triggered the attack. And honestly, I've had some asthma patients that we had no idea what triggered the attack. And they didn't either. I've also had a lot of them that exercise induced and allergy. Secondary assessment addresses the chief complaint. Perform after identifying and treating life threats such as your ABCs. Check for a change in mental status. Check the patient's respiratory status. Oh, go back to this. Most common ways we check the mental status is what?
Person, place, and time.
Person, place, and time? Well, yeah, we usually do on the ambulance. Oh, my crew does. What day is it? What month is it? Year?
Oh, yeah.
And
I
I
give you
jotted
nickel,
down
dime, and a
person,
quarter, how
place,
much
and
money you got?
That was a noun.
Yeah, you throw that one out. That's for
What's a noun?
intellectual people.
I wanna see if they're tracking.
Yeah, that's right. Check the patient's respiratory status. Look for the signs of increased work of breathing. Assess their circulation. Check for signs of trauma or retractions in the chest. Obtain vital signs. Use monitoring devices if available. All right, reassessment. Repeat primary survey and maintain an open airway. Monitor patient's breathing and reassess circulation. Confirm adequacy of interventions and patient status. Reassess and record your vital signs. Emergency medical care. Perform standard interventions. Oxygen to keep the saturation above 94%. So see, I know we said 91, but 94 is what they want you to keep it above. Psychological support. Decrease the work of breathing. Remove constricting clothing. Do not make person walk, and do not lay patient supine. We actually had a patient years ago. A couple of you guys know this. My dad and Mick White got to an ambulance call, car wreck, and the girl had her seatbelt on, but she couldn't breathe. So they were checking her and stuff like that. And they would have said, "Man, we gotta lift up your shirt because we gotta see, you know, if you've got a bruising and all that." So they lift up the shirt, no obvious bruising of any sort. And she's just, I mean, she's struggling to breathe. And they're checking her lung sounds and all that, and looking around inside the car. And she didn't hit anything they can tell. And they said, well, so they said, they cut her shirt off, they're checking that. Nothing obvious there. And they said, okay, well, they cut the seat belt. No, nothing there, that's not making any difference. And finally they said, well, ma'am, we're gonna have to cut your bra. And they go, and she says, it's brand new. She says, I'm sorry. So they just took it, just cut it. And they said it flew open. And Sir said that all of a sudden she goes, well, that's better. So, believe it or not, clothing can cause the problem. So it does happen. So, all right, provide supplemental oxygen. Administer oxygen in the concentrations necessary to be effective. So in other words, nasal cannula, mask, CPAP. I'm noticing they're doing CPAP now, and then obviously bag or ambu bag. Pulse oximetry is a useful guide to oxygenation. Safe to administer oxygen concentrations less than 50% to almost anyone. Oxygen saturation of 100% should be avoided. What is something that gives 100%? Any idea?
Non-rebreather.
Non-rebreather does.
Bag valve.
What?
Bag valve.
Bag
Ink
valve?
tube,
Huh?
BVM.
combi, ink tube.
Well, but that doesn't have any oxygen, you gotta put oxygen on
Yeah, you gotta turn the oxygen on.
it, which comes from a BVM.
Yeah.
Yeah, so, yeah, you that girl. That's what I like to see.
Let's
So-
say making friends today.
You're number one, Jim.
Emergency medical care. Administer a bronchodilator. Patients who do not have bronchospasm usually do benefit only slightly from aerosol bronchodilators. Bronchodilators are of little value in treating conditions such as pneumonia, pulmonary edema, and heart disease. Respiratory medications. Most common medications used for dyspnea are inhaled beta agonists, which is what we refer to as. You guys don't remember what the inhalers are called?
Oh, albuterol?
Albuterol, there you go.
There's a bunch of them.
That's most common, I see, that we use, that we see. Secondary bronchial constriction could be reversed with a bronchodilator. Common side effects of inhalers are tachycardia, nervousness, and muscle tremors. Aerosol therapy. Aerosol nebulizers deliver liquid medications as a fine mist. To generate optimal particle size, post nebulators need to have oxygen flow of at least 6 liters per minute. And I think that is something that they're gonna have us learn, right? Isn't that one of the new things that's coming up?
One of the meds that we'll have.
Yeah, is
Nebulizer?
nebulizers.
I don't have any experience with those.
We used to have them.
Well, yeah,
in the
yeah.
ambulance.
I know, oh, no, through my kids.
Aerosol therapy, a nebulizer can be attached to a mouthpiece, face mask, or tracheostomy collar, or held in front of the patient's face. Metered dose inhalers direct medication through the mouth and into the lungs. Achieving proper technique requires constant reinforcement. Metered dose inhalers, patients should try to inhale the medication deeply, then hold their breath for a few seconds. Contraindications include patient is unable to help coordinate inhalation. MDI is not prescribed for this patient. Patient had already met maximum prescribed dose. Anybody remember what the maximum I guess it says on the things, doesn't it?
It's not.
It varies.
Like 3.
If you take it, you just can continue to take it.
3 doses max.
3 doses is max, isn't it? On
Mhm.
most of them? What, no, say that again, Tyler?
When I take my inhaler, I take it when I need it, and I don't think I've ever really followed the whole.
Yeah, well, that's encouraging.
Okay, all right. We're gonna use Tyler as what not to do.
Explains a lot.
Well, you're not gonna overdose on it.
Well.
Yeah,
you can.
You can.
Actually.
You can, yeah. Oh, yeah, I got you. I see what you're saying now.
Stop talking, Tyler. Stressing me
Medication
out.
is expired. Go ahead, Tyler, you said. Oh, that's more of a
Also-
suggestion than a rule.
Also, just a suggestion.
Yeah. And no, it's not. For those intensely. So, okay. Emergency medical care, dry powder inhalers, reasonably convenient and easy to use, rarely used during emergency care. I've never seen it used on an ambulance. I don't even know. Any dry?
I didn't know they existed.
I didn't either.
It's rarely used.
Huh?
It's rarely used anymore.
Is it rarely used anymore? Okay.
It's
So I'm
mostly our,
supposing
like
stick where you
severe
want.
COPDers that get.
And that's usually in a hospital setting though, right? Not even there.
We have them at the Pioneer.
Oh, do you? Okay, okay. Consider fluid balance. Give a fluid bolus to younger patients. In older adults and patients with cardiac dysfunction, administering too much fluid could cause pulmonary edema. Support or assist ventilation. If a patient becomes fatigued, breathing might need to be supported more aggressively. Some patients may simply require bag mask ventilation for a short period. Gastric distension and vomiting can occur from over-aggressive ventilation. Continuous positive airway pressure, so CPAP, used to treat obstructive sleep apnea and treat respiratory failure. Many people with obstructive sleep apnea wear a CPAP unit at night. It's a continuous positive airway pressure system. Administering CPAP increases pressure in the chest by be vigilant and about monitoring the gas supply. Bi-level positive airway pressure. One pressure can be delivered during inspiration and different pressure can be delivered during exhalation. Causes a pressure variation in the chest which allows for more normal blood flow, more complex and expensive. So is that going to be a, oh crap. We're always see it in the hospital or if they.
Yeah, I don't think we're gonna see that one unless it's on a transfer probably.
Yeah. What I can't even think what it's called. The breathing.
Protocol?
Huh?
What? I guess I wasn't paying attention.
The bi-level positive airway pressure. Isn't that going to be a ventilator?
No.
That's not a ventilator?
Nope.
Okay. Because it's delivering expression. Huh. Okay. All right. Assessment and management of specific conditions. Upper or lower airway diseases. Patients present with signs of severe respiratory impairment. Chief complaint is typically dyspnea, cough, or nocturnal dyspnea. Wheezing may be present. Place patient in position of comfort. Monitor airway, apply high flow oxygen, and assist ventilation if needed. Transport and contact medical control. Acute pulmonary edema may be associated with cardiac disease or direct lung damage. Administer 100% oxygen. If necessary, carefully suction any secretions from airway, provide assisted ventilation, establish IV access, and monitor flow rates carefully. Aspiration, inhalation of anything other than gases associated with a high mortality rate. Avoid gastric distension when ventilating. Aggressively monitor the patient's ability to protect his or her own airway. Aggressively treat aspiration with suction and airway control if the previous steps fail. What's an example of one of the common aspirations we see around here?
Vomit.
Vomit, right. Vomit's a really common one.
In fact, I would have probably picked vomit as the most common, but I know it's not now. But,
I don't know, I think it probably is, isn't it? I don't know.
no, I said food. I think you said food was the most common airway obstruction.
Obstruction, this is aspiration, where you actually breathe it in.
Okay, then it's vomit.
Then I would think it's vomit, yeah. We'll go with it. I don't think it's gonna be on a test, so. Chronic obstructive pulmonary disease, patients often find breathing difficult while lying down. Assist with a prescribed inhaler if there is one. Auto PEEP, what's PEEP?
That's
A
the
PEEP valve?
change in the amount of pressure that's being put into your,
Should be
Positive.
ventilated at a rate as little as 4 to 6 breaths a minute.
Positive.
Such restraint is difficult, but it's
Positive
absolutely
and
necessary to avoid the dire
expiration
consequences of
Positive
raising
what?
thoracic pressures.
Expiration pressure.
Positive ended expiration pressure. I hope that was not a test. Okay. Asthma, assessment of patient is critical, often recurring pathological condition. 3 components are bronchospasm, airway, edema, and increased mucus production. Be prepared to suction any administer oxygen. Asthma also use slow, gentle breaths when ventilating. Emergency care of child is the same as an adult. Status asthmatic is a dire emergency, or the dire medical emergency. Aggressive airway management, oxygen administration, and prompt transport are essential. Anaphylactic reactions, remove the offending agent, maintain the airway, administer supplemental oxygen, assist breathing as needed. Spontaneous pneumothorax. Management begins with the ABCs, provided airway and ventilatory support. Watch for signs of tension pneumothorax. We went over those a little bit earlier. Pleural effusion. Treatment is a removal of fluid collected outside the lung. Provide oxygen and other routine support measures. Pulmonary embolism. Manage the airway and provide high flow oxygen. Initiate CPR for pulselessness and apneic patient. Manage most severe cases of cardiac arrest of unknown origin. Hyperventilation can be caused by life-threatening illnesses or panic attack. Give supplemental oxygen and transport. Now, I've never understood that one.
It says never place a paper bag over a hyperventilating patient's mouth and nose. If hyperventilation is a
Now, I
result
did, believe it or
of
not,
hypoxia or other life-threatening conditions,
I've had a couple doctors tell me to go ahead and put,
rebreathing carbon dioxide could be lethal.
so I've had a couple of the doctors tell us that we can go ahead and use the mask
that jump.
and put them on oxygen and then shut the oxygen off. That's what I actually had the doctors tell me. If you suspect that. If you're showing it's 100% oxygen saturation and their hands are curling and all that stuff.
We'll get to that, E-Court and
Yeah,
serve it.
all that stuff. And they're having tingling all in their extremities and all that. That's usually a sign of hyperventilation. So just take the mask and just pull it down.
But it typically produces a falsely high oxygen saturation reading.
Well, yeah.
I just usually breathe with me.
Oxygen should never be withheld from a patient complaining of dyspnea. The rate of oxygen is based on symptoms and pulse oximetry readings. Remember the factors such as carbon monoxide toxicity, which could also result in hyperventilation, may produce a falsely high saturation reading. If through the patient's history, anxiety-related hyperventilation is confirmed, coached ventilation should be considered. When in doubt, always provide 100% oxygen.
Okay. And then provide psychological support
what
for
they're saying
anxiety-related
is-
hyperventilation.
Coach ventilation, that's what I would call what I do.
Psychological support.
Coach them, like,
Coach 'em.
focus on me, breathe with me, slow
Right.
it down.
But go ahead
Trying
and
to
give
get
them.
them slow down their breathing.
Back to the mouth.
Yeah, they're saying not to withhold oxygen.
Yeah.
And not, I mean,
Yeah,
giving them a mask and then shutting the oxygen off might not be a good.
Well, no, you need to give them oxygen if it's not making any difference. And you know what? Just drive like hell. Just get them to the hospital, let them,
They're saying go ahead and just give them one too and
yeah,
drive like hell.
yeah.
Let the hospital.
I had one where they told us that we did give the 100% oxygen, and they did tell us that if they would've gone much longer, by that, he never gave a time frame. But it could actually be very detrimental. How's that? Didn't say it would kill him, but indicated it might. So I don't know. We need a doctor to sit there and tell us that.
According to this.
Right. Okay, so obstruction of the airway. Upper airway obstruction may be a partial or complete. If patient can talk and breathe, provide supplemental oxygen and transport. Remove obstructing body according to basic life support guidelines. Administer supplemental oxygen. Environmental and industrial exposure. Industrial sites often have their own medical fire hazmat teams. Once the patient is decontaminated, gather information or substance and cause of dyspnea. Provide 100% supplemental oxygen or assisted ventilation if necessary. If upper airway is compromised, aggressive airway management may be required. Bronchiolitis. Treatment is entirely supportive. Provide supplemental oxygen to be prepared to assist with bag mask device. Respiratory syncytial virus. Look for signs of dehydration. Treat airway and breathing problems. Croup often responds well to humidified oxygen. Allow patient to assume position of comfort. Avoid agitating the patient. Administer nebulized epinephrine if dictated by a local protocol. Epiglottitis. Keep patient in position of comfort. Do not put anything in patient's mouth. Give high flow oxygen. That's literally all you can do. Pneumonia.
Drive like hell.
Don't suction then,
Yeah, it doesn't say to yet.
unless you have an obstruction.
Monitor ABC, pneumonia. Monitor ABCs, provide high flow oxygen, ventilate, support as needed. Administration of IV fluids may help. If high fever is present, cool patient. How are we gonna cool patient?
We got our ice packs.
Huh?
We've got our ice packs.
Yeah, ice packs under. Pertussis. Some infants and younger children should be treated in a hospital. Watch for signs of dehydration. Administer oxygen as needed. Airway obstruction in children. Clear the airway, provide oxygen and transport. Heart failure. High blood pressure and low cardiac output often trigger sudden pulmonary edema. Treatment should consist of airway, ventilatory, and circulatory support. Tracheotomy dysfunction. Children with chronic pulmonary medical conditions may use a home ventilate connected by a tracheostomy tube. Establish a patient airway, place the patient in a position of comfort and suction to keep that clear the airway. Once the obstruction is clear, oxygenate the patient, treat based on presentation. Establishing airway patency is the immediate goal for geriatric individuals. Epidemic and pandemic considerations. Am I going too fast?
Last slide, go for it.
Oh, okay.
One more slide.
Epidemic and pandemic considerations. Epidemic occurs, well, we just dealt with pandemic. When new cases of disease occur in a human population substantially exceed what is expected based on recent experience.
Wear a mask, right?
Wear a damn mask and put some goggles on and wash your hands and your face after you're done. All right, wear PPE. If anybody doesn't know what PPE is by now,
Holy crap.
holy crap. Maintain your vaccinations and stay up to date on the latest CDC recommendations. That's what that slide says. Now,
How many of us have been shot already?
wear a HEPA respirator during aerosol generating procedures.
Shot, what do you mean shot? I
Vaccinated.
haven't been shot yet.
No, vaccinated.
So, you want to take a break real quick while we set up the next
Yeah,
one?
because it's gonna take a while for me to get into the next one.
Okay.
I'll go next so you get a rest.
Maybe I'll write a patient report.
Oh,
Oh, yeah.
from
yeah,
last
from
night?
Yeah, you just get on that.
I think you can probably do the.